Good evening, everyone, and welcome to tonight's very special Wound Care Today Facebook Live. A massive thank you to all of you for joining in such vast numbers. It's massively appreciated. My name is Ed Rusling. I'm the CEO of Wound Care Today, and this is my friend Gluco, who you'll be hearing a lot more about in the 45 minutes ahead. We have an exciting evening ahead of us, as tonight is the launch of microworld.
Join us on a journey to another world, a world of the invisible. Welcome to the micro world of wound care.
So here we go. Tonight's event is called Wound Healing Principles, a new animated way to learn. And our amazing speakers tonight are Joy Tickle and Jenni MacDonald. Good evening, both of you.
Hi everyone.
How are you guys?
Good.
Good. Well, thank you so much for joining us on our adventure tonight. Ladies and gentlemen, as you can see, Joy and Jenni are doing tonight's event from home. So if we have any technology problems, please bear with us and we'll get them sorted as soon as possible. The event is available on Facebook Live forever. We'll also be putting it on the Microworld website and on the Wound Care Today website, woundcare-today.com, where you can download the slides. We get loads of questions about slides. You can download them from our website. The link for your certificate of attendance will be made available towards the end of tonight's event, and that will count towards your revalidation portfolio. As Jenni and Joy will agree, the more engaged you are, the more involved you are in tonight's event will make a massive difference to them and to the event in general, especially with the Microworld launch. We want to know your views. We want to know your challenges. We want this to be the best it can be possibly be for you. So let us know, make comments, but also ask questions, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. Before we start, two big thank yous. Firstly, to our Microworld partner, who are Mölnlycke Healthcare. It takes real bravery and courage to support something brand new and something that's completely different to the status quo. So a massive thank you for your trust, belief, and engagement with us over the last 2 years. It's hugely appreciated. It's a genuine privilege to work with a market-leading expert as yourselves, and we look forward to transforming the world of wound education over the years ahead. And secondly, to the team at Get Animated and Wound Care Today. I'm well aware of the time, the effort, the blood, sweat, and tears that's gone into this. So be very, very proud of Microworld. Thank you so much. So, ladies and gentlemen, without further ado, it gives me great pleasure to introduce you to tonight's first speaker. Over to you, Joy.
Thanks, Ed, and welcome everybody. I'm really excited that Jenni and I are going to be sharing this new way of learning through Microworld with you. I'll start by beginning addressing the learning objectives of this evening. At the end of this evening, we'll hopefully be able to appreciate the different learning styles and their importance in enhancing the way that we learn, the experience of learning. To understand the different components that make up Microworld, to understand and appreciate the importance of the structure and functions of the skin and the wound healing process itself, and to understand how Microworld can offer an enhanced learning environment and certainly cater for lots of different learning styles. So as I've mentioned, we all learn in different styles, don't we? And it's important that teaching and education materials embrace the different styles. There are 7 main learning styles, as you can see on your screen. There's the visual, where we prefer using pictures and images and spatial understanding. There may be the oral style of learning, where we prefer sound and music. verbal or linguistic, where we rely both on speech and the written word to learn, and that's quite traditional. And physical, so we prefer using body, hands, sense of touch, and that's very much like the hands-on type of learning. And I know for myself, through my nursing career, I've used a lot of the physical hands-on type of learning. Logical is the mathematical, so that's where we're preferring using logic and reasoning behind our learning. Social, as it says, it's interpersonal. We like to learn with others in groups, or just individually with others, or smaller groups, or solitary. So we very much like to learn on our own. So we prefer to work alone or have self-study. Now, it may be that you have different learning styles for your different environments. I mean, do you find, sometimes I do anyway, personally, it's how I'm feeling sometimes is how I want to learn. Sometimes I want that social and interpersonal. Sometimes I want that visual. Sometimes I want to very much study or learn on my own. So, you know, it's ensuring that teaching and education, as I've said, can meet and embrace all those different styles of learning. So microworld. It made me start to think, when I first looked at microworld, about the different learning platforms, different ways we learn, different analogies that we use, and you know, and how adaptive that might be. Now, recently, more so than ever, we've had to be very adaptive in delivering our healthcare, and I think we've become very good at doing that as well. But I think equally, we have to be adaptive in delivering our learning as well now. What microworld does, you know, the key points are on your screen, but what it is, it's a non-traditional approach to learning, but it's simple, it's fun, and it translates globally. And that's what Ed was saying. This is going to be globally across the world. So it's going to be delivered in different languages and facilitate what I think is a real life global learning network. It's free and accessible, and I think that is so crucial that education is made freely available and accessible to all. It importantly allows us to complete modules. Now, that's important not only for your professional development, for me, myself, for my revalidation, but also then it opens up other areas of microworld where we can continue learning in different formats. I found, and I have used it, and I have experienced microworld myself. What I found is that complex content, so things that, you know, like this evening, we'll be talking about the phases of wound healing, the layers of the skin. So that complex content is delivered more engagingly, more interaction. There's animation, there's characters, there's illustrations, games. It delivers learning in a variety of different learning styles, so it can meet the needs of the wider audience. And it uses analogies so that we can learn and remember those complex processes more easily. What I want to make a point of saying here is that most of us tonight will be, I would imagine, the majority healthcare professionals. What I will say is I've looked at this now, more importantly, for our patients, families, carers, and all other discipline platforms. You know, we're seeing more supported self-care for our patients, and that may involve carers. We need to be educating our patients and supporting them. And we're not just talking older patients, we're talking young patients as well. And I think this is a fantastic opportunity to use some of these modules to assist that. We believe that that education and wound care is delivered freely, but not in all countries. And it made me reflect on that. In many countries, you know, wound care is delivered by the patient, the person themselves. Wound care is delivered by their family. They don't have clinicians to deliver wound care and help with wound healing. Sometimes it's not affordable either, and the patients can't afford it. So again, looking at the environment to where we need to support the patients and the carers. But what excites me, we've got the characters, and I'm going to introduce you to some of microworld's characters this evening. And the characters will help us to learn and remember these complex processes a lot more easily. Now, Gluco, you can see these characters on your screen. You've already met Gluco. He's sitting next to Ed, our chair this evening. And as we know, Gluco, or glucose, is the body's main primary source of energy. So these characters are the key elements, the key essential requisites for the wound healing process. But what a good way to remember them. We have Mr. X, who is exudate. It's the fluid produced by the wound to maintain that moist wound level, bathe the wound, cleanse the wound, often perceived, Mr. X, as the bad guy, but actually exudate is the good guy. Without exudate, we would not facilitate the wound healing process. We have MAC, the cleaner, MAC or macrophages, and they detect, engulf and digest that bacteria and debris. So imagine they are cleaning up the wound. We have NUT who assist MAC in that cleaning process. NUT is the white blood cells, the neutrophils, again essential for triggering the tissue injury inflammation response, and again destroys harmful bacteria and debris. And along with NUT and MAC is MC. MC is the larger white blood cells, or the monocytes, and these larger white blood cells actually transform into macrophages and again assist the other two in cleaning up the wound itself. Scarlet, you know, the name says it all. Scarlet is the bright red, essential red blood cells, the main cell of the blood which picks up the oxygen from the lungs and delivers it around the body, and also, of course, to the wound bed and to the skin itself. I like clots work. Clots work helps me to remember what is essential in the first phase of wound healing. Those small blood cells, or the platelets, which can assist, which cause the blood, to clot and form that clot. We have the essential controller, essential growth factors. This is the main guy, the big controller, because without those growth factors, again, it wouldn't stimulate the wound healing. And those growth factors are initially released by the platelets on injury, but also by the macrophages and other cells along the wound healing process. Now, within our characters, we have two sets of twins, two very important sets of twins. The pro-twin protease enzyme, and that's an enzyme that breaks down proteins in the damaged wound tissue. And we have the pro-twin protease inhibitor. Now, that enzyme ensures that the proteases only break down the damaged protein, not the healthy essential protein we require for wound healing. We have the yellow and blue energy balls, as I call them, nutrients and oxygen, essential nutrients and oxygen that are providing energy and resources for the wound healing process. And finally, those fibroblasts and myofibroblasts, as you can see on the screen, they have those long, thin cells, long, thin arms that reach out. And what they do is pull the edges of the wound together and speed up that wound healing process itself. But by using the characters and understanding, it's a simpler way of remembering. So our first class, the class that Jenny and I are going to be presenting to you this evening through Microworld, is the wound healing class. Now, this class takes us through the function and anatomy of the skin. It takes us through the four phases of wound healing and explains how wound closure occurs. Now, as practitioners, it really is important that we understand the skin. We understand the layers of the skin, and we understand the wound healing process that needs to take place. If we understand it, we can implement appropriate skin and wound care to assist the body, the patient's body, in facilitating wound healing. That knowledge will assist us in not just implementing wound healing, but appropriate objectives for wound healing. If our objectives are appropriate, we can then ensure effective wound management and successful healing outcomes. So we're going to give you a preview of Microworld, a taster of parts of the wound healing class. And we're going to review the skin, as I've said, and discuss the wound healing process and give you a feel of what Microworld is like. So I'm now going to hand over to Jenny, who's going to discuss the skin. Thank you, Jenny.
Thanks, friend. So I am going to jump in to a little bit of anatomy and physiology of the skin. For some of you, this might be a refresher, or for some of you, this might be new. So as we know, the skin is the largest organ in the body. It actually takes up 16% of our total body weight. But we all know that the skin needs to remain intact to allow the body to perform the vital functions that it needs to do. But it's really important to understand the functions of anatomy and physiology of the skin. And we can't overestimate that, because when you are assessing a wound, for example, you really need to be able to appreciate at what stage of wound healing that particular wound is at. And if you don't understand your anatomy and physiology of the skin, then it's going to be really difficult to do that wound assessment. So I can't emphasize the importance enough. Now on this slide, looking at the layers of the skin, I'll go through each one individually, but this is a good image to show you how the microworld platform actually animates the different levels of the skin, and again makes that more accessible to the learner to understand the different levels. So the epidermis. The epidermis is the outer layer of skin that we can see on each other. The outer layer is actually dead. It's flat cells, and it varies in thickness across the body. So for example, your eyelids are the thinnest part, and the thickest part is on the soles of the feet and the palms of the hands. And the reason for that is we're continuously, through friction, sloughing off the top layer of epidermis. So it needs to be thicker on the hands and the feet. Like I say, the epidermis has no direct blood supply. And actually, again, this is when it's really important to understand the different layers. The epidermis receives its nutrients and its oxygen by diffusion from the dermis. So from that second layer up to the top layer of epidermis that we can see. What you might not know is actually the epidermis regenerates itself every 28 days. So now we're going to go down a level of the skin to the dermis. It's the second layer of skin. And when that's exposed, it looks like a beefy red color, we would describe it. And it's composed of fibrous proteins mostly. But essentially, the dermis is the layer of the skin where, when I'm teaching, we'll say this is where the party's happening in the skin. Everything's happening in here. So in the dermis, you've got collagen. Essentially, it's a framework, it's a scaffolding that holds everything together and gives it that strength. It's also got elastin, which gives us that flexibility and elasticity to move as we need to. So in the dermis, you've got blood vessels, you've got different types of nerves. So you've got nerves that will signal to your brain in terms of changes of temperature. You've got nerves that will tell you about touch. It will tell you about pain. So there's loads of different nerves in your dermis. And again, all the things, there's blood vessels, there's lymph vessels, there's so much going on in the dermis. And each of these structures all have a different function, which together will are responsible for the functions of the skin, which I'll touch on in a second. The thing to remember about the dermis is when we get older, the dermis actually loses 20% of its thickness. So if we think about our older patients and their dermis becoming thinner, that makes their skin more fragile and more susceptible to injury, like skin tears, for example. So to go down another layer of the skin into the subcutaneous or the fatty tissue, if you're in America, you would call this layer the hypodermis. And essentially, this is the deepest layer of the skin and is made up of adipose and connective tissue, so your fatty tissue. It does contain some blood vessels and nerves, but they are larger in this layer compared to the epidermis. And essentially, your subcutaneous tissue anchors the skin to the skeleton, but allowing some movement at the same time. Again, increasing with age, we have to think about this layer of skin as well. Thinking again about our more elderly patients, the amount of the subcutaneous tissue as we get older again decreases. So that's when we're thinking about our patients who are older actually have less protection in terms of the amount of subcutaneous tissue, again putting them at higher risk of things like pressure ulcers. Now that was a quick recap, and on the next slide I'm going to show you how the microworld platform actually tells you what I've just told you, but in an animated and easily accessible way.
Level 1, the epidermis. Comprised of dead flat cells, on most of the body it's thin, 0.1 millimetre, but 1.2 millimetres thick on your palms and the soles of your feet. The epidermis has no direct blood supply and receives nutrients and oxygen by diffusion from the dermis. Level 2, the dermis. The second layer contains blood vessels, nerves and cells, and the structures responsible for the functions of the skin. All of this against fibrous proteins of collagen that holds the body together, and elastin that gives flexibility and elasticity. Level 3, the subcutaneous tissue. The deepest, densest layer, made up of adipose and connective tissue that contains and protects larger blood vessels and nerves, anchoring the skin, allowing for some movement. And now you know what you need to know about the skin, it's time to watch the wound healing team in action.
Excellent. I hope you enjoyed that. It was certainly the first time that I saw it. I was quite blown away. It's super retro. I love it. So just to come back to the functions of the skin. So we know the skin has 5 major functions. First of all, it acts as a barrier to microorganisms in the environment, which protects us from infection. We know the function of the skin. It helps us to regulate temperature with the hair follicles. And it also has an excretion function as well in terms of sweat. The other thing we have to think about is our melanocytes that are in the epidermis, that top layer that I was talking about. The melanocyte cells actually gives us our pigmentation, which varies from person to person. And the reason that cell is particularly important is it absorbs UVA and UVB light, which gives us some protection against skin cancers. Again, another function of the skin is to synthesize vitamin D. Not all of us have enough of it, especially north of the border. And obviously, the skin acts as a form of sensory perception. I was talking about that when I was mentioning the different types of nerves. And the one thing that we have to remember that's often forgotten in terms of the function of the skin is communication. Now, how many times have you walked past your patient and thought, oh, there's something not quite right there? It might be that your patient looks quite pale or quite clammy, flushed or sweaty. And actually, that's the body's way of communicating to you that systemically something on the inside is not right with your patient. So please don't forget that the skin is a form of communication as well. So wound healing processes. Now, Joy's going to go a little bit more into the phases of healing, but I know this can get a little bit complex because there's different processes and there's different categories and there's different phases. And that terminology can get quite confusing. Again, the microworld platform makes that a little bit easier to understand. But just to kind of recap, so in wound care, we tend to categorize wounds into acute wounds and chronic wounds. And acute wounds essentially heal in a timely fashion, just as they're supposed to do. Whereas chronic wounds get stuck in the second phase of healing, and Joy will touch on that. So the inflammatory phase, which in normal wound healing is absolutely normal, but chronic wounds for some reason get stuck in this phase and then don't progress in a timely fashion. The wound bed changes, we start looking into getting biofilms and potential infections, and chronic wounds essentially change the way that they heal. So that's 2 ways to categorize acute wounds. An example would be a surgical wound or a traumatic wound like a skin tear or a burn. They would sit in the acute wound category. In the chronic wound category, you're looking at potentially a diabetic foot ulcer or a venous leg ulcer, for example. The other key way to categorize wounds is the way they heal. So you'll often see us TVNs talk about primary intention and secondary intention. And essentially, this is the way to describe the way the wound is healing. So more often than not, acute wounds will heal by primary intention. And what primary intention means is we purposefully pull that wound edges together. And you'll usually see that in surgical wounds. A classic example of a wound healing by primary intention is either by clips, sutures, or wound glue, for example, where we pull that wound edges together. So that's healing by primary intention. Chronic wounds heal most often by secondary intention. And most of you on the call tonight will know the terminology from healing from the inside out. And essentially that's what secondary intention is. So we don't pull the wound margins together, we heal it from the bottom up. So again, this is when it comes back to that layers of healing. You'll be able to see your different layers. So healing from your subcutaneous layer up to your dermis layer, and then up to your epidermal layer. So that's healing by secondary intention. And now I'm going to hand you back over to my friend Joy. Thanks, Joy.
Thanks, Jenny. I mean, Jenny, you're right. The skin is such an essential organ of our body, but I agree with what you were saying, that it is quite complex and we don't always look after it as well as we should. But by having an understanding of the skin, you can understand then how wounds can heal or cannot heal in some instances. So I think it's really good to definitely go over the structure of the skin and the wound healing itself. So I'm going to be talking to you a little bit about the wound healing process itself, and it is very complex. It is a complex sequence of events. It's very orchestrated, and learning about the wound healing phases, it can be, but as I've just said, very complex. Of course, wound healing starts when the injury first occurs. It ends when the tissue is repaired and strengthened. And traditionally, it's often described as four main phases: hemostasis, so we get the blood loss is prevented; inflammation, proliferation, and maturation. And traditionally, we know those four phases, as you can see. But it doesn't mean we can't use different ways of describing the wound healing process. Within the microworld module, we've used an analogy that makes learning the phases of wound healing easier to remember and easier to implement. But what I will add, it's still in line with the traditional four phases, as you can see on your screen, of wound healing. But as we know, particularly I do in wound care and when I'm nursing, some simple analogies can really assist us in learning and remembering information. So let me share this with you. We're going to look at the wound healing phases, but what we're going to use here, Microworld have used Shipley's emergency response analogy. And what they've used that for is to assist you in understanding the phases of wound healing more simply, but helping you to retain that information also. But as I've added, still bearing in mind the four traditional phases. If as the clinician, we can identify where that wound is within the wound healing process, we can then make appropriate decisions that can make and ensure effective wound management and wound healing to final complete closure. And I'm going to give you some examples of that during each phase as we discuss each wound healing phase further. So this is phase one. This is the inflammatory phase, but again, I'm using Shipley's analogy, the analogy of the emergency response analogy. So this is the initial injury. This is phase one. Okay, this phase lasts anything between 0 and 3 days, the inflammatory phase, and it's like to emergency response by firefighters. So imagine this emergency response. Here we have hemostasis. And we have the arrest of blood loss. So we're trying to stem that blood loss. So following wounding, the platelets or clots worth release the factors that result in the vessels vasoconstricting and the formation of that platelet plug. So we're stemming that or dampening out that loss. The inflammation here is a normal process. It's a normal vascular and cellular process of injury. And without the inflammatory response, wounds wouldn't move along the healing continuum. Following the initial injury, when the blood vessels have constricted and we form that clot, we have the opposite occurring. The blood vessels then dilate. They need to dilate to carry essential cells to the source of injury to allow healing, okay? And those classical signs through this phase 1 or the inflammatory phase is what you see, that evidence of redness, heat, it's painful, there may be swelling around the injury, and that's a result of histamine and prostaglandin being released at the wound site. What does that mean to you in practice then? Some practical points on this point is you will see that heat inflammation. But what normally happens during this phase, and I've experienced this many, many times, is those classic signs of inflammation can often be confused with local wound infection. So I have patients who ask me for antibiotic therapy and they don't require it because they feel their wound is infected because it's similar signs to the inflammatory response. I have clinicians who request antibiotic therapy or antimicrobial therapy, and it's not necessary, but as long as we educate our staff and educate our patients, this is a normal response and anticipated between 0 and 3 days of initial injury. So, you know, more now than ever, we have to be really strict with our antimicrobial and antibiotic stewardship. And this is one key point, that if we learn about the inflammatory phase, we can really reduce that overuse there. What we must remember, practical points in practice, are that some patients who are immunosuppressed, so those on medications that lead to immunosuppression, or patients with comorbidities such as diabetes that can lead to immunosuppression, may not typically show these clinical signs of inflammation, and may also be in what we call a prolonged inflammatory response, which can lead to delayed wound healing for these patients. So know your patient, understand that the holistic factors that may affect this inflammatory phase. What I will add here is during the inflammatory phase, we'll have an increase in exudate. That is natural. We will tend to see that nice, thin, watery, clear exudate. And don't forget, as I said, Mr. X, the exudate, is essential at this point to bathe the wound and to bring essential cells to the source. If we're aware that that is happening during the inflammatory phase, we'll be prepared for it. We'll inform our patients that the wound exudate might increase, that they may see leakage from the wound, and that we are prepared with the appropriate wound dressing that will assist with that. So you can see how all of this understanding and knowledge can help you manage your patient's wound during each phase. Phase 2 then. This is the destruction phase. This is where we have the refuse collectors who come and clean away all the debris, all the fire debris, in the case of the wound debris. They're going to come and clean and prepare the site and allow it to be restored. Now, we don't, you know, traditionally we haven't used the term destructive. It's not used in the 4 traditional phases, but I think it's a really good way of delivering a simpler approach to understanding this particular phase of wound healing. This destructive phase lasts anything between day 1, or occurs, between day 1 and day 6. It's a natural process, but this is where we are preparing and cleaning, and the refuse collectors are working. The key components here are the neutrophils, or NEUT. They are the first responders, the white cells that infiltrate, multiply within an hour of injury, and destroy bacteria and debris from the wound bed. When the white cells die and the NEUTs, the neutrophils, do die, they'll become a sticky substance, and that's known as slough, and it's a natural part of phase 2. Important here, we have our monocytes, or MC, and MCs are attracted to the area also, like the neutrophils. They transform into macrophages, or MAC, and they continue with that really important cleaning activity in order to process or promote that wound healing. Practical points here for you during the phase 2, then, this destructive phase. The presence of exudate is normal here, it's vital, and we require it. So we don't certainly want to be drying out any wounds. We want to encourage the exudate production. But what we need to do is also make sure that exudate, or Mr. X, is carefully managed. Because of course, exudate will also contain waste products during this phase. It'll contain waste bacteria, debris, dead white blood cells. So we need to be able to manage that exudate, contain it, within the wound dressing, prevent it from becoming prolonged contact with the wound and the peri-wound skin, because it will damage the wound and the peri-wound skin if it's left in contact for long periods or not managed effectively. During this phase, as we've said, it's the destructive phase. We're cleaning, we're preparing that wound bed. You may also, during this phase, be facilitating that preparation. So wound bed preparation here, you'll be considering your cleansing techniques, your debridement techniques, any dressings that you may want to implement to assist all these cells to promote that debridement and removal of devitalized tissue and slough. So you at this point will be considering making those decisions around this phase of wound healing. Phase 3, this is the proliferation phase. This is what we call rebuilding. So it's the builders restoring the structure of the building, you know. So we've put out the fire, we've stopped the blood loss, we've cleansed the air, we've prepared the site, and now we're going to restore the structure or the building. We're going to restore the underlying structures, as Jenny's talked about, the layers of the skin. This can take between 3 and 24 days, and we've got the builders, as I've said, restoring that structure. Here, it's the important macrophages that release the controller or the growth factors. That controller, the growth factors, stimulate the formation of new blood vessels, which is known as angiogenesis. That delivers the oxygen and nutrients through the yellow and blue, as I call them, the energy balls, to the new tissue, bringing through that oxygen and essential nutrients. What happens during this proliferation phase also is the capillaries start to form together, and they form a scaffolding, almost like a building scaffolding over the wound. And that scaffolding then can develop into nice, rich granulation tissue. The important elements here are the fibroblasts. They start to divide as well and produce collagen. And as we know, collagen builds elasticity and strength to the wound. And it's giving us that elasticity and strength that we require. Practical points here during phase 3 or the proliferation phases, the wound now becomes a very rich vascular network. It's a network of capillaries, and it's very fragile and very permeable. And that's what contributes then, what we may see as some local tissue edema and the appearance of granulation tissue. We might also see during the proliferation phase a slight increase in the amount of exudates as well. But this tissue is very fragile, very rich vascularly, and we need to protect it. But the colour of the granulation tissue, in practice, as a clinical tip to you, is a really good barometer of the wound healing process. So healthy granulation tissue is that nice, moist, red, bright red in colour. And we know that's nice, healthy granulation tissue. And the wound is going through while the proliferation or phase 3. However, if that granulation tissue becomes dark in colour, you might see bridging across a wound bed. You might see that granulation tissue bleeds easily. That can be indicative of possible local wound infection or a poor vascular supply to the tissue. So it makes you then rethink about your key objectives during this phase of the wound management. If the tissue is nice, healthy granulation tissue, then your practical point is you want to protect the granulation tissue, promote the epithelial tissue to reproduce, and maintain that really healthy, rich, moist wound environment. The final phase, phase 4, is the maturation phase. It's the final stage of repair. And how we link this is to the decorators. So we've restored the building now, we've formed the new building or the new structure of the wound, but what we want to do is restore it to its former appearance. We want to give it its final former appearance, the final phase. Now, maturation phase can last anything between 21 days and 2 years. And it's important you're aware of this because we need to educate and support our patients. And I'll talk to you more about the tips on that in a minute of why we need to do that. But during this phase, your fibroblasts change into the myofibroblasts. Remember me telling you about with their long arms and what that allows them to do, the long cellular thin structure, allows them to contract around the wound edge itself. And then what they do is help to migrate from the edges of the wound and bring the wound edges together. Okay, so we're trying to see the contracture of the wound edges, pulling them closer together, and that's the fibroblasts and myofibroblasts doing that. Once that starts that process during phase 4, we get new epithelial cells that start to migrate from the edges of the wound over the wound bed itself. Here also during this phase, hair follicles, sebaceous and sweat glands are being influenced at this point by the growth factors and being re-stimulated and reformed, thinking of the final form appearance. Practical tips here, what you will see during this phase is those pearly white cells appearing on the wound. So they look like a very almost shiny pearly white appearance. What we don't want to do is dry them. We want that moist wound environment to allow further epithelialization, but also to protect those new epithelial cells. Now, in some instances in practice, you might find that because the wound surface area is a wide area, particularly in some patients with burns, then sometimes this epithelialization or final phase, we may introduce a skin graft to facilitate that covering or that defect covering more speedily. So that is why sometimes skin grafts, but the normal process is the epithelialization and those cells across the wound bed. What we don't want to do here is lead to any delay in the epithelialization and the maturing. So we don't want to delay the wound closure. Unfortunately, if we delay this phase of wound healing, it can lead to significant scarring, and it can lead to the formation of contractures. So it can be quite upsetting for patients if we don't process through this phase of wound healing speedily. So the reason I put here about promote education for your patients is that maturation can take, so maturation is gaining the strength back, and we know that wounds or skin that's been injured will never gain 100% of its original strength, approximately 80% of its original strength. And during that maturation phase, we still need to educate the patients that the wound is still healing, underneath the structures and on top, and that they still need to look after the skin, they still need to protect it. And, but quite often I've had patients who see the wound closed and feel they can then go about all their daily activities, go back to the gym, do all sorts of activities that actually they don't understand that wound is still quite fragile and still maturing, and they need education on how to support and protect that area as well. So we've talked about the 4 phases of wound healing. We've seen the great animation and Jenni's brilliant presentation about the importance of the skin. And what I loved when I went through the module, what I like personally is that I can repeat and recap on the classes, as often as I like. And I know myself that sometimes I like to do that. That's my learning skill. Sometimes I go to work and I reflect a little bit on wound healing and think, I think I'll just recap on that. And that's a real good benefit of microworld, is you can repeat and recap the information. It also allows you to take a test to assess your learning, and that isn't a test that I've failed or I've passed. What a test does is help you to look at your strengths, look at the weakness, some of the weaker areas that you don't quite understand, and to look at different recapping on the module again, or doing other processes, other learning skills. And what I also like, we're all busy. That goes without saying. You've all given your time up this evening to watch this presentation. We're busy at home, we're busy at work. So how difficult, I know for myself, it is to monitor and keep an accurate learning progress. And this does it for you. So it keeps that accurate learning process. And as I've said to you, not just professionally, it also helps to support your ongoing revalidation and knowledge and skills. What it also does is give us a fantastic microworld dashboard. And what the dashboard does is it gives you access to new content, helps you to view your activity, visualize and track your monitoring. There's games on there. You can set challenges. It's a fun way of learning. So with the dashboard, it opens up other ways of learning. It opens up other opportunities. And as I've said, there's games on there that you can learn just by and challenge and have little competitions between yourself and your colleagues as well. So it's a fantastic opportunity of learning via the dashboard.
Joy, can I just jump in there a second?
Yes, certainly.
You've told me before that you're quite competitive.
Mm.
So I'm just asking for a friend. What's your top score?
I'm not going to tell you, Jenny. See, I think that's really neat. You've used a live audience now to ask me what my top score is on my game. Okay, I'm going to put it to you. What's yours?
157.
Oh no. Okay, I'm not telling you what mine is. But
you just really know.
It isn't as good as yours, but I think you've obviously had more opportunity to go on the game. But anyway, I think that just absolutely shows that I am competitive, and so is Jenny, and we're good friends, and how actually learning is quite, well, it is extremely fun, especially when you can bring in a little bit of humour and challenge with it. So yeah, Jenny, I think that's I'll have a little discussion with you at the end of tonight as well, and I'll set you a challenge for tomorrow. So thank you, Jenny, for that one. So I'm going to conclude now. I'm going to conclude this evening's presentation before we go to the questions and answers. What I hope you have found useful, and I certainly feel excited, and I know Jenny does, is that Microworld offers a new animated way to learn. It caters for lots of different learning styles, and you've only seen a small part of that this evening. We really must understand the importance and the functions of the skin, the anatomy, and understand and appreciate the wound healing process. But we can do that in a real, clear, simple way. And by having the clear understanding, we're going to make the right decisions, set the right objectives for our patient's wound healing process, and ensure we put in the appropriate management as well. And I hope that by using a simple analogy, as the emergency response analogy we've used this evening, it can break down complex information and aid understanding a lot more simply. So I'm now going to hand over to Ed for our question and answers. Thank you, Ed.
Pleasure. Very quickly, Jenny, I'm on 161.
Oh
no!
No!
Guys, thank you. That was amazing. Quite emotional watching that, actually, and how much work's gone into that animation. There's a 10-minute animated module that I can't wait for everyone to see, because I think it will blow you guys away. I want to crack on with the Q&A, if that's okay. So question one, Jenny, I'll start with you, if that's okay.
Yep.
Who is the Microworld most relevant for?
Ooh, probably anyone, to be honest. So like Joy said in her presentation, there's more advanced information there that for people that have been in wound care for a long time. So I've got 5 brand new TVNs starting in the next 6 weeks. This is going to be perfect for them. What a great introduction to a specialist role. So brand new TVNs, more experienced TVNs. Again, not just your specialists, your generalists as well. So we, in my health board, we're doing a lot of work with care homes at the moment. So actually, this is a great thing to be able to tell care homes to log in, sign up, have a look at the module, and then give us some feedback and see what they think. I think it's ideal for care home staff as well. I don't know about in your workplace.
I mean, yeah, no, I totally agree. I was thinking, we might, some of the specialists who are watching or might think it's not a specialist platform, but actually as a TVN lead, and I'm sure you can agree with this, Jen, to me, it's an absolute tool in my toolbox for education. It's a platform I'm going to use, certainly, when educating staff within my own workplace, whether that be TVNs up and coming, whether it be clinicians, and I'm certainly going to, use it on all sorts of, residential homes that we work in, But for me, it's an added educational tool in my toolbox. And, you know, I don't think any of us have the luxury of developing lots of new different educational presentations and things. So to me, as a specialist, I will be using this in my toolbox, and I think, you know, it can be used anywhere. I know for myself, sorry, you've got me talking now, Jenny, but I'm working alongside a lot of really good clinicians, and the thing that really resonates with me is its global approach, because it's going to be multilingual. Most of the, you know, a lot of the practitioners I work with, English isn't their first language. So when this is translated into different languages, what a fantastic way we can come together. But not necessarily as English as our first language. Yeah,
thank you, guys. And we're also hoping that it's going to get shared with patients and their carers. We want to make sure that the animation can be split into 45-second videos, 1-minute videos, that will really hopefully empower the patient and their carers to understand what's going on.
And Ed, let's not forget our children. You know, our children are our patients. Children are patients, I'm trying to say. So what a great way to support them.
So question 2, Joy, coming to you. Does education need modernising?
I think education always, I think any part of, if we're talking healthcare, I think healthcare, education, I'm going to say it. I do think there is elements of education that need modernising. I think sometimes it can become a little bit, I might get shocked saying this, a little bit tired, a little bit stale. What I'm trying to say here is this doesn't detract us away from the importance of articles, research, evidence, all the other ways that we learn. But I think that isn't for everybody, Ed. You know, the ways of learning now, we can become more modern. We can become a little bit, you know, make it a little bit more interesting. But let it complement that other ways of learning as well. But I do feel we have to, you know, reinvigorate, I think, sometimes, not just education platforms, but the way we deliver education and training as well.
Brilliant, thank you. Joy, for you, question 3. Can you repeat the module after you finished it as a refresher or a reminder about what it covered?
Yeah, and I'm sorry if I didn't sort of emphasize that or sort of I didn't say it clearly. But yeah, you can repeat the modules as many times as you like. Many times as you like. So, you know, and that's what I like about that. I am a person who, it doesn't matter if I read an article, it doesn't matter if I watch a video, I like to go back and repeat it. And that's just the way I learn more effectively. So the luxury of this is you can repeat it, you can sit in your car and do it, you can sit in the bath, you can, you know, I mean, I do have, you're all sat this evening giving up your time, but you can do it in work time, home time, waiting for the children to finish the football match or gymnastics. I just think it's a good way of learning. And
on the bus,
recapping on the bus, on the train. Not aeroplanes at the moment, but maybe the train. But it is, Ed, I think that recap is so important. You know, I know myself, I can't just watch something once or listen to something once. I like to recap.
So next questions I can probably answer actually from Susie James. Thank you, Susie. Question is, how do we get access to microworlds, and will there be more modules content after this one? So the website is www.mymicroworld.online, and we're going to put that up on slides at the end. It will go in the comments, but it's mymicroworld.online, and we are launching 14 other modules over the next 2 years. The next one's coming early autumn on wound exudate. And we have a plan involving leg ulcers, diabetic foot ulcers, pressure ulcers, wound infection, etc., to hopefully provide a platform that we can build on, not just over the next 2 years, but over the next 20. So yeah, please guys, log on. Next question. This is for Jenny. How does one tell the difference between local wound infection and the inflammatory response?
I think Joy touched on that one. It is really difficult, Ed. Obviously, you know, and the reason it's difficult is because the signs and symptoms of both are the same. So you get that redness, that kind of hot to touch. You might get some pain response from the patient describing it to you. You might get an increase in exudate. I think it's very, very difficult, and that's what Joy was saying in her presentation. We jump too early to antibiotics because we think it's systemic infection, and actually it's not. It's that normal inflammatory phase. But if you, again, going back to the presentation, if you don't remember the phases of healing, then you're going to get that mixed up, and you're potentially going to give your patient antibiotics when they don't need it. And I'm not going to go into antimicrobial stewardship because that's a whole other Facebook Live. But yeah, it's understanding the anatomy and physiology, and understanding the signs and symptoms, and again, monitoring. If I'm concerned, I'll have the patient, I'll go and see the patient, or the patient come back maybe tomorrow or the next day, and often marking it just as a backup measure to see if that erythema is moving. Because if it's not spreading infection, then it won't cross that marked border.
And no, I think that's really, really good, Jenny. And also, like you say, if you know the phases of wound healing, and you know, ask the age of the wound. When did this injury occur? And if they're saying, oh, within the last couple of days, then the chances are, know what caused the injury, because yes, some wounds could become infected because of the nature of the injury, such as a trauma injury with debris. But ask the age of the wound. When did this injury occur? You know, and that's why we have the days, you know, the phases with days on as well. So, but yeah, it can be difficult, but that's why we have these education platforms.
So 3 more questions to go, because I'm aware that time is flying tonight. So this one's from Liz Wilson. So Joy, if you want to answer this first. My understanding was that inflammation was the first phase, then proliferation, maturation, and epithelialization. Hemostasis was not discussed. Would epithelialization be stage 5 then?
Oh, I love that question. Yeah,
really been watching
next time. Yeah, hemostasis is part of that initial inflammatory response. So it does come under the heading of the inflammatory phase. Please challenge me if you think I'm wrong, but it is a good way of looking at it. Should we have 5 phases of wound healing then now? So it's the hemostasis, but the hemostasis is part of the inflammatory response, which is between 0 and 3 days. And without the hemostasis, you know, obviously we would have the bleeding and we wouldn't be able to stem that. And without that hemostasis and the release of those platelets, and that then stimulates the inflammatory response as well. So I hope that's answered it. You could argue that we might need 5 phases. I think it's already complex enough with 4. And I think, you know, it is classed as being part of the initial injury stroke the inflammatory phase. Okay,
so I've been told the next question is the last question. And actually, incredibly, it's for me, which is a worry. A lot of people have asked, is microworld free and how could we access it? So yes, it's absolutely free. For those of you guys who've engaged in our business, everything we do is free. We don't charge delegate fees for our events. All our content's free. So microworld is absolutely free. And as you'll see again in a second, it's mymicroworld.online. Register, go in. I urge you to watch that first module. It's 10 minutes long. Engage with it, have a play around. But please let us know your thoughts. We really want this to be the best it can be, and your feedback's going to be critical to that. Please challenge us. Please tell us what you want in the future, but let us know. We have a whole feedback mechanism on the website, so engage with that. Let us know, and we'll make it right for you. So, guys, you know, that is the last question. Jenny, Joy, I mean, I'm seeing some incredible comments coming through that are very kind. So, thank you so much to everyone watching. You were amazing tonight, guys, and please watch your back, because the comments are telling you how amazing you are. So thank you so much. Ladies and gentlemen, for more events, education like this, please feel free to go to our website, which is woundcare-today.com. Our partners, Myrmica, if you like this, they've got a fantastic event coming up on May the 11th, early evening. It's entitled, How Can We Keep the Burden of Wound Care from Bleeding the System Dry? A Patient, Provider and Payer Perspective. I've seen the list of speakers, it's fairly insane. So please log in on that on May the 11th, early evening. So guys, you know, the action here is we want you to go to
Try it out.
online. We want you to watch that module. We want you to engage, and more importantly, we want you to tell us what you think. It's really important to us we get it right. So comment, let us know, and we will make it the best it can possibly be. The link for your certificate of attendance for tonight is now available. So click on that, download that, and that's now, I should be on the screen and certainly in the comment bars. And that concludes tonight's event. Massive thank you to Jenni, Joy, really appreciate it tonight. Thank you so much.
It's been a pleasure.
Big thank you again to Monica for your partnership, hugely appreciated. To the team, Get Animated, Mold Digital, Wound Care Today, ludicrous how you put these things together. So thank you for your hard work and your patience with me as a rubbish chair. Thank you to Gluco for contributing throughout. And last but not least, thank you to you guys watching for your continued loyalty, for your support, and for your passion for education. Stay safe, stay strong, have a lovely evening, and we'll see you very soon. Thank you very much.
Good night.